Neck weakness in MND, an investigation of prevalence and physiotherapy management, a retrospective descriptive study from Timothy Sheehy.
Hello, my name is Tim and I'm a physiotherapist at Calvary Health Care Bethlehem, working in a statewide specialist MND clinic in Melbourne, Australia. Today I'm going to talk about a study we've been working on for the last 12 months, looking at the prevalence of neck weakness in MND and how the head support strategies change over time. I want to give a special thanks to Monash University for their collaboration and to the MND Association of Victoria for their funding of this research. And thank you to the International Alliance of ALS for giving me the opportunity to talk about this subject again. Now I'm going to break down this talk into three parts. Firstly, talk about the background of neck weakness in MND, then explain the study design, and then finally delve into the results. These first two slides are just a reminder about the background of neck weakness in MND, which I presented at this forum back in 2019. Firstly, the literature reports that neck weakness in MND is pretty rare, with figures showing a prevalence of 1 to 3%. We felt as a department this to be significantly underreported from our observations at our clinic. The onset of head drop varied greatly, with the same papers showing as early as 3 months to as late as 8 years from the first symptoms of MND. And because these two studies had such low numbers of people with neck weakness, there were 9 cases in the first study and 3 cases in the second study, there isn't enough data to analyze their cohort and whether there is a trend of neck weakness within specific phenotypes. We know that neck weakness is correlated with poor respiratory function, which is important to be aware of for timely interventions for both respiratory deterioration and for neck weakness management. And this second slide is to remind how much of an impact neck weakness and head drop can have on a person with MND's quality of life as well as their carers. So it's important to make sure that we can manage the neck weakness properly. Before we explored the prevalence of neck weakness and what interventions were used for head support, we completed a smaller study in 2020 with 33 of our patients with neck weakness. They answered a questionnaire about their neck weakness and the various head support strategies they were using at the time of answering the questionnaire. As you can see, up to 5 strategies were used in a given day, with either 2 or 3 strategies being the most common. We also gained insight in the most common strategy being used, which was positioning backwards into tilting or recline and using a soft collar. It was really interesting to see the variety of neck collars being used and the variety of other head support strategies being used by our patients. So within 6 months of collecting data, we already had 33 patients with neck weakness. Therefore, we wanted to take a step further and work out the prevalence of neck weakness with the larger size and see if there was a relationship between neck weakness and phenotype. Also, as a follow-up from our smaller study, we wanted to know how many head support strategies people used throughout the condition and if there were any changes over time. From August 2020, we screened 510 patients from our clinic with MND, and 358 patients met our criteria. We excluded patients that had pre-existing conditions, other than MND, that could affect their neck weakness. We also excluded patients who were still alive at the time of data collection, and symptom onset started less than 18 months ago. So we still include patients that were still alive, but have had their MND symptoms for at least 18 months. We collected all relevant data from their medical records for analysis. So moving on to our results and starting with details and characteristics of our cohort. You can see that the common phenotypes were lumbar, cervical and bulbar onset MND, with PLS and flail limb rounding off our cohort as the rarer phenotypes. This data shows that our cohort is similar to the general MND population based on previous research done by Professor Tallman and his team in 2016. And when we look on the right hand side of the slide at those who had MND related neck weakness, we can see that the mean age and gender distribution is very similar to our overall cohort. So, prevalence of neck weakness. Our study confirms what we suspected, that neck weakness is far more prevalent than 1 to 3% previously reported in literature. Our study found a 39% prevalence, and it may even be higher, as some of our cohort had not fully lived out the extent of their progression, which means that there is potential that some of those who could also develop neck weakness as their progression continues. As an example, when we looked at the data of those who had passed away, which was 194 participants, 54% had developed neck weakness. It should be noted that this cohort is limited to those who live in the state of Victoria in Australia, and it'd be interesting if other countries could explore this as well to ensure that this is not limited to us. When we break it down and look at how prevalent neck weakness was within each phenotype, we find that neck weakness occurred in over half of those with bulbar onset MND. Neck weakness was prevalent in 41% of our patients who had cervical onset MND, and just under a third of those who had lumbar onset MND. Looking at the PLS and flail limb phenotypes, the sample size were too small to be able to be confident with any of those numbers. So when does neck weakness start? Remember, in the two papers I've spoken about before, they reported the onset range from 3 months to 8 years since the start of their MND. Our results show that the median onset of our overall cohort with neck weakness was around the 2 years, with neck weakness occurring as early as the first symptom of MND up to as late as 22 years, which occurred in someone with PLS. When we compare the onset of neck weakness between the common three phenotypes of bulbar, cervical and lumbar, the numbers are all pretty similar, around the 2-year mark. Now looking at the results of the head support strategies, we grouped the various strategies into the following types. Positioning, which meant using recline in the recliner, or tilting backwards in the high back chair, or the manual wheelchairs and the power wheelchairs, which our patients have access to all of these through the MND Association of Victoria Equipment Library. Neck collars were split into 3 different categories. The soft collar, the semi-rigid collars, which included all of these collars, and then the rigid collars, which included the Aspen Vista and the Philadelphia collar. Other supports included specialist headrest, which were defined as a headrest other than their standard headrest that came with their wheelchair, and which was required specifically for their neck weakness. So here we have a Y-shaped headrest and an L-shaped headrest, and then the Savant headrest, which all our patients have access to them through the MND Victoria Equipment Library. There were also cushions and pillows, as well as various head supports, which included using a cuff and collar strap and a baseball cap with elastic straps to the headrest. Now that we've gone through what the strategies are, here is the data looking at how many different strategies our cohort went through throughout their MND. Okay, so what we can see here is that the number of strategies range from no strategies at all up to 7. So to give you an example, the one person who used 7 strategies throughout their life started off first with positioning, then used a soft collar and a separate rigid collar for different tasks. Then once they were using a wheelchair, required a specialist headrest, and then used a baseball cap with elastic straps for forehead support, which was then followed by some extra cushions, and then in the later stages of their life, finished with a forehead strap instead of the baseball cap. Almost half of our cohort had at least 3 head support strategies in their lifetime, which shows us that a lot of our patients don't just need advice on positioning and a single collar, but are likely to need to go through a variety of strategies as their condition progresses and their disability increases. Moving on to breaking down the total number of each strategy prescribed, and we can see that positioning and soft collar were the 2 most common strategies. This is consistent with what we saw in our earliest smaller study in 2020. A reason for this is likely because reclining or tilting back is a comfortable position for most people, as long as their respiratory function can tolerate it. It doesn't involve any pressure under their chin or forehead, and the equipment to get into these comfortable positions are made available for free for our patients with the help of MND Victoria. The soft collar is the cheapest and easiest to use out of all the collars. Therefore, it's easy to see why it's a common strategy used by our patients, especially at the start of their disease, which I will demonstrate with the next slide. It is also a collar that we frequently modify to maintain independence. It is interesting to see again, much like our smaller study, the wide variety of interventions used for head support. This continues to reiterate that neck weakness management isn't a one-size-fits-all approach, but a specific management for each individual. So when are these strategies prescribed for head support? Well, looking at this first graph, we can see that getting our patients to recline or tilt is mostly in the very first appointment, once they start developing neck weakness. Looking at the second graph, we can see that soft collar is prescribed either together with positioning as an early intervention or in the subsequent review. Prior to collecting data, we would have guessed that the semi-rigid and rigid collars would have been prescribed later on, once the soft collars were no longer providing adequate support. What's interesting in our data, though, is that it doesn't really show any trend about this. And finally, when we look at the other strategies, we can see that the specialist headrest is prescribed later on. One big limitation to this data, though, is that MND can be such a quickly progressive condition. many of our patients did not likely live long enough to have frequent physiotherapy reviews of their head supports, which is likely a reason why you can see that all strategies reduce greatly after the second or third intervention point. Our last set of results explored the number of collars modified to help with comfort and tolerance of the collars, as well as independent use. Our results show that 38% of all soft collars required some form of modification, and over half of the rigid collars also required modification. Of those rigid collars that were modified, they were all Aspen Vista, and none of them were Philadelphia collars. And only one semi-rigid collar required a modification, which was a headmaster for some extra padding. And here are the specific modifications that were used. Satin sleeve was used in 11% of all soft collars to help keep it cool and more comfortable for the skin. A soft strap instead of the back component of the Aspen Vista was used for half of those collars to help with comfort. A self-release lanyard was also used to help allow our patients to remove their collars independently, and this was used for a quarter of the soft collars and a fifth of the Aspen Vista collars. Note that to have a self-release lanyard for the Aspen Vista collar, they need to have the soft strap instead of the back component. And lastly, some padding was required for a very small number of the collars. There were several limitations to note from our study. Firstly, the study only occurred at a single site, which could lead to bias with regards to the prevalence number and the various head support strategies prescribed. Secondly, our data collection was collected retrospectively from medical records, and so the accuracy of our data relies on the accuracy and detail of the notes in the patient files. Thirdly, not all our patients had lived up to the end stage of MND at the time of collection. So as I previously mentioned, this could affect the prevalence number and also the number and timing of head support strategies prescribed. Lastly, from the patient files, we were unable to get reliable data on the effectiveness of the strategies prescribed for head support. This is probably something that's better done in prospective studies. So in summary, our results have shown a prevalence of 39% for neck weakness in MND, which is much higher than previously reported. Neck weakness should be a key symptom to look out for in our patients to ensure they have the appropriate care to improve their quality of life. There is a high prevalence specifically in bulbar onset MND when compared to other phenotypes. Positioning and soft collar were the most commonly prescribed strategies. However, there was a wide range of various head support strategies used, not just one or two strategies. And modifications are often required for neck collars, especially the soft collar and the Aspen Vista collar, to optimize comfort and independence. Managing neck weakness isn't a recipe. It needs to be patient-centered and reviewed frequently to ensure they continue to be appropriate and check whether the strategies need to be modified or changed entirely. This concludes my presentation. Many thanks for listening.
I was going to say, where are you, Timothy? That was really interesting. That was a nice review of what people are using out there. And let me see if there's any questions. I, of course, always have questions. You know that.
Yep.
Somebody wants to know if you collected any information on patient satisfaction with the collars.
So we tried to, because it was looking back through the notes, we tried to collect data on how often they use the collar and also how long before they stop using it, they cease, then move on to the next intervention. But there was so many missing data that we had to scrap that part of data. And I think that's something that is better to measure in a prospective study where you can actually control those variables and ensure you can ask the right questions.
Mm-hmm. Yeah, then you know what you're collecting. You can set up what you're going to collect and what you're going to ask. You might have written it in some charts, but not in other charts.
Exactly, yes.
Yeah. Would you consider, I know you were saying you didn't have the full chart of somebody, so would you consider doing a retrospective review where you do look at the full lifetime of the person and only include those people that you would have the whole?
Possibly. I think it will depend on obviously the phenotype. Some of our patients, especially those who have flail limb onset or PLS, will live still for very long. So it depends on who's still at the center in 5-10 years collecting the data.
Mm-hmm. Mhm. Well, it was I mean, it's really nice to look across that and share it with other health professionals, because we all know we're doing some of those same things when we're adding the Velcro so somebody can get the collar off, and we're modifying the back to the collar. So if there's people watching, there might be people out there watching today who are like, oh, I didn't know you could do that, or I didn't think about doing that. So even
Yep.
showing that is, I think, very useful.
And I'm sure other centers around the world have got their own tricks and tips and modifications for their, for collars that they commonly use. So we would love to hear what they use, because I think the more we can spread this message, the more then our patients can have better comfort and better quality of life.
Absolutely, because it is such a huge issue. And that actually was one of my other questions, is what was the criteria? I'm sorry if I missed that, but what was the criteria that you chose to say they had neck weakness? Were you doing a manual muscle testing? Was it subjective?
Because it was always looking back into the notes. So these notes could have been, some of these notes were 5-6 years old. The way we standardized it was, as soon as a person complained of their head feeling heavy, or they struggled to keep their head upright, or objectively, if a physio managed to manually muscle test or objectively note that they had a head drop, then that was part of the criteria. But not all of our patients had been muscle tested, purely because of the many different therapists that would have worked at our center in the last 10 years.
Mm-hmm. Was it any complaints of neck problems? Did you know, what about stiffness or pain, or was it?
So stiffness is interesting. Pain, we didn't include pain as the date of onset if purely pain was the issue, because pain could be a number of things, and we know that from other research that's not related to MND. We had to have a weakness component to it. Stiffness is very interesting, because I think stiffness is what makes managing head drops so difficult. And it'd be, I don't know what the next step is to try and reduce stiffness or reduce the risk of stiffness, or what are the risk factors that lead to stiffness, because it would be some patients have really low tone, really floppy heads and necks, and they're really, well, not really, but they're simpler to manage, because there's normally less pain, and there's less having to modify, and there's less constraints on other collars being used. Those who do have stiffness then also tend to have a side tilt to their head, which then makes it even more difficult, because you've got to think about pressure care. Where does the pressure come into with the collars under the jawline rather than just under the chin, and around the ear as well. So stiffness is a real tricky thing.
Yeah. Did you notice a change in brands or styles of collars over the time? Like you maybe used a different collar, a Philadelphia collar in the past and a Vista now?
No, we didn't. I didn't look specific, or we didn't look specifically at what was, I guess, in fashion, every couple of years. It probably would be good to know, because things like the head up collar from Sheffield, it's obviously new on the market, so that's something that would be more commonly used more recently. But yeah, no, we didn't have a look at that.
All right. I don't see any other questions. So if you don't have anything else to add, we will go ahead and move on.
Thank you very much.
But thank you so much. And maybe we will do a multi-center look at that. We could do a global look at.
We would absolutely love it. We would.
All right. Thank you so much.